so much for the invitation to present. It's a pleasure because I've been attending these workshops in the past, and so it was very special to get that invitation in turn to share with you my group's approach to metabolism. So the technique that we use is something called chemical cartography, making these 3D maps of how metabolism changes over space. So the way chemical cartography works is that we collect organs or multi-organ systems, and then we section them in a way that reflects organ physiology, as well as what we currently know of disease processes. We build 3D models that show the position of each of these segments in 3D space. And then for each segment, we extract metabolites. For each extract, we perform liquid chromatography tandem mass spectrometry, and then we rebuild the data back into 3D. And so that lets us visualize the relative spatial distribution of specific metabolites, metabolite families, and then connect that to aspects of disease physiology like pathogen load, local tissue damage, local immune responses, drug penetration, etc. Now, one of the major diseases to which we've been applying chemical cartography is Chagas disease. Chagas disease is caused by the parasite Trypanosoma cruzi. And so this is a unicellular parasite that alternates between intracellular and extracellular stages inside the mammalian host. And so the parasite itself is endemic from South America all the way up into roughly the center of the US. But this is also a very initially asymptomatic disease. Many people don't know that they're infected with T. cruzi. And so people will move to other places. And so the Chagas disease is now a global problem. And one particular challenge with Chagas disease is that while we have antiparasitic agents, if treatment is delayed until late stage symptomatic disease, those treatments, even when they do successfully clear the parasites, are not actually enough to improve patient outcomes. And so that suggests a role for host pathways in Chagas disease progression. And so that makes Chagas disease a good system to apply chemical cartography. Another reason why Chagas disease is a good fit for a chemical cartography approach is because it causes highly localized symptoms. In cell culture, T. cruzi is able to infect pretty much any nucleated cell, but in the human body, symptoms are specifically localized to the heart, the esophagus, and the colon. And so a key question for us is, well, why those specific locations? What's different there compared to other sites that the parasite is able to infect? And so we'll start with the heart first. So in the heart, T. cruzi will invade inside the cardiomyocytes. And then that will cause death of the cardiomyocytes either through direct parasite effects or through immune-mediated mechanisms. Those dead cardiomyocytes get replaced by fibrotic tissue that impairs electrical signal transfer in the heart. It impairs cardiac contractility. One particular characteristic aspect is also these aneurysms that develop right here at the tip of the heart. And these are actually very characteristic of Chagas disease. There's very few other conditions that cause aneurysms right here. And so as we look at cardiac Chagas disease from a chemical cartography point of view, what we're interested in is the differences between what's going on at the heart apex compared to what's going on in other parts of the heart. And so to look at this, we used a mouse model of Chagas disease. And so we had mice that were infected with two different parasite strains. And so we can plot where the parasites are in the heart. So with this strain here, lots of parasites at the top of the heart. Whereas with this strain here, parasites are mainly in the middle regions of the heart. We can then contrast that with where metabolism is affected. And so what we find is that in both cases, we have a disconnect between where the parasites are and where metabolism is significantly changing. And with strain Silviox 10.4 in particular, the only site where we had significant metabolic changes was the heart apex. So matching very nicely with our sites of Chagas disease symptoms. And so this can help explain why symptoms develop specifically at the heart apex. We then looked at this question from a more temporal point of view. And so this was in collaboration with partners at Baylor College of Medicine. And so we collected samples at 50, 75, and 142 days post-infection, collecting from the right and left atrium, and then the top and bottom of each ventricle. And so what I want you to look at is the slopes here as we transition from 75 to 142 days. For 4 of the segments, the slopes are going down. And so that means that the magnitude of metabolic perturbation, so the impact of infection on metabolism at those 4 segments, is decreasing as you transition to late chronic stage. But for 2 of them, the slopes are increasing, so things are getting worse, more metabolic perturbation. And those 2 segments where we see an increase, those are the bottom segments of the 2 ventricles. So again, matching very nicely with our sites of symptom development. We can then look at the specific metabolites and metabolic families that are affected at these locations. And one particular group of metabolites that we see changing is glycerophosphocholines. So these are membrane constituents, but they also play important signaling roles as well, particularly in relationship to immunity. And what we find with both strain CL as well as strain Silvix-10-4 is that we have an increase in glycerophosphocholines in the lower half of the heart, or specifically significantly at the heart apex with strain Silvix-10-4. And you can see it also here on the box plots. Red and gold are infected and blue is our uninfected control. Now, this is still a pretty small change. The reason I feel comfortable showing this to you is because we validated this in a completely independent mouse model. And so what was nice with this infection condition is because in addition to having just binary infected versus not, we also had different measures of disease severity, including cardiac inflammation, cardiac fibrosis, and the profibrotic cytokines CTGF and TGF-beta. And what we find is that these indicators of disease severity are positively correlated with glycerophosphocholines across mass ranges. So that means that the worse the disease, the greater the increase in these molecules. The other way we've been approaching this is by doing single-cell metabolomics in collaboration with the Young Lab at the University of Oklahoma. And this is necessary because during chronic T. cruzi infection, parasite burden is actually quite low, so you'll have one infected cell surrounded by many uninfected cells. And so we can mirror this in vitro. So we have beta-galactosidase expressing T. cruzi, so infected cells stain blue. And so you can see here we have several infected cells surrounded by multiple uninfected cells. And so what we find is that these infected cells specifically have greater levels of glycerophosphocholines compared to all the other experimental groups. So nicely validating at the single cell level what we saw on the macroscopic level. What was also interesting, though, is when we look at the PCA plot here, each of these spots is summarizing the metabolome of a single cell. And so here the red spots are showing the infected cells, the green spots are showing these bystander cells. And what's interesting is that not just the infected cells, but also the bystander cells are divergent from our control cells that came from a completely non-infected well. And so that means that just by being near infection, even if a cell is not itself infected, there are metabolic consequences. And I think that's very important in terms of how we think about drug development as well, because our efforts are primarily focused on these cells here, but we're seeing consequences of infection here as well. Okay, so for cardiac Chagas disease, what I showed you is that we have this disconnect between where the parasites are and where metabolic changes are happening, but this very nice concordance with metabolic changes versus sites of disease symptoms. We have changes in, I showed you data for glycerophosphocholines, but we also changes in multiple different chemical families, including acylcarnitines and purines. And these changes are proportional to disease severity. Moving on to gastrointestinal Chagas disease. In this case, megaesophagus and megacolon are the symptoms. So you have enlargement of those organs that affect the movement of food through the esophagus, exit of feces through the colon. And so likewise, the question here is, well, what's different in the esophagus and the colon compared to the rest of the gastrointestinal tract? And so to answer this, we collected the entire mouse gastrointestinal tract, beginning from the esophagus, 3 segments of the stomach, 5 segments of the small intestine, the cecum, and then 3 segments of the large intestine. And we collected samples both early after infection, 12 days post-infection, and then also in the chronic stage. And we had data from 2 independent infection cohorts. And so overall, this brought us to 637 samples, or 9 days of data acquisition. And so we can look at specific chemical families and how they change across the gastrointestinal tract with infection. And so if you remember, in the heart, we had increases in glycerophosphocholines. And so I show you here the example of one glycerophosphocholone in the GI tract, which we find increased in the esophagus, as well as the distal colon in infected mice compared to uninfected samples. What's interesting, and something that we would have missed if we weren't doing a spatial analysis, is that in the small intestine, we actually have the opposite pattern, where we have a decrease in this same lipid with infection compared to uninfected samples, showing that for one particular molecules, you can have spatially divergent effects of disease. Here's another example. This is kynurenine, which is a molecule that's produced under inflammation conditions, but can have anti-inflammatory activities. And so we see a largest increase of kynurenine in the proximal and central segments of the colon. And what's nice with this data is that kynurenine is produced from a tryptophan precursor, and we see a small decrease in tryptophan at those same sites. And then we also have changes in many different acylcarnitines. So acylcarnitines are major intermediates in fatty acid metabolism. They're important to import fatty acids into the mitochondria for beta oxidation and energy production. And what we find is a large increase in this acylcarnitine in the esophagus, as well as in the small intestine. And you can also see it nicely visually here in infected compared to uninfected samples. And this increase persists in the esophagus as you transition to the chronic stage, but renormalizes in the small intestine. And so if we look at this more globally, on the left here, you have parasite distribution, and these 2 plots are on a common scale. So early after infection, lots of parasites pretty much throughout the gastrointestinal tract. But then the immune system kicks in, helps control parasite burden, and so parasite numbers decrease to low but non-zero levels. Right away, if we look at how much metabolism is being affected, so red is bigger impact, you see right away there's not a one-to-one match between where the parasites are and where metabolism is changing in acute stage. And what we were particularly interested in is how these patterns change as we transition to the chronic stage. And so in particular, in both the esophagus and the colon, parasite numbers are going down, but the degree of metabolic perturbation is actually increasing. And so this can help explain why symptoms do develop at those sites, because we have what I'm calling poor metabolic resilience, an inability to go back to normal as pathogens are cleared. In contrast, the small intestine, especially the distal small intestine, is strongly affected early after infection when there's lots of parasites. But then parasite numbers go down, small intestine renormalizes. And so this can help explain why symptoms do not develop there. Now, the next question, of course, is, well, why is the esophagus not as resilient as the small intestine? And that's something we're actively investigating. I think it'll keep us busy for quite a while still. But what I showed you for gastrointestinal Chagas disease so far is that, like we saw in the heart, we have this match between where symptoms develop and sites where we have significant metabolic changes. And I brought up this idea of poor metabolic resilience in both the esophagus and the colon. In parallel with these changes in the metabolome, we also have changes in the microbiome as well. And we have changes in specific metabolites and metabolic families, including glycerophosphocholines, kynurenine, and acylcarnitines. Now, for the remainder of the talk, I want to take us from these fundamental insights into disease localization, into translational applications in terms of using metabolism to diagnose Chagas disease, and also using this to think a little bit differently about drug development. Now, Chagas disease, people can be infected with T. cruzi, they can stay asymptomatic for years, they can even stay asymptomatic for their whole life. Only about 30 to 40% of infected people will actually progress to symptomatic Chagas disease. And so there would be good value in being able to predict if a patient was going to progress or not to symptomatic disease. And so initially, to look at this, we used our mouse model. And so we collected samples from infection conditions that were known to either lead to fatal infection or non-fatal infection. And so what we found is that we had very good predictive accuracy to predict either fully fatal infections or non-fatal infections. But this was done using cardiac tissue samples, which is not really a clinically applicable approach, especially not on a large scale. So instead, one of my former graduate students, Danya Dean, was really interested in looking at biofluids. And so she set up a mouse infection where we did temporal sampling up to 90 days post-infection. And so we have three groups here, the infected group in green, the uninfected group in orange, and then as a control, we have chemically induced cardiac damage, which is induced by a compound called isoproterenol. And so this will help us differentiate between metabolic consequences of any kind of heart disease versus metabolic consequences that appear to be significant to Chagas, specific to Chagas disease. And so we looked first at saliva. And so those lines here show the metabolic trajectories of each group over time. In saliva, all the colors are all tangled up. That means that there's basically no differences in terms of overall salivary metabolome between these three groups. When we looked at plasma, we had some significant changes at early time points. So you can see that this green line, the infected group, diverges from the uninfected group in orange. But notice that the isoproterenol lines are also going in the same direction. And so that means that, yes, we are seeing metabolic changes in the plasma with infection, but many of them are in the same direction as those induced by chemical heart damage, so less likely to be specific to Chagas disease. On the other hand, when we looked at urine, we saw a very large shift in the urine metabolome with infection, and this was divergent from both uninfected mice in orange, as well as our chemical cardiac damage in purple. So then in collaboration with the Penn lab, they built GLMM models to find metabolite features that changed with infection status and over time. And then we did targeted metabolomics on an independent infection cohort to validate these biomarkers. And so what we find is that, so for biomarkers, you want both high sensitivity and high specificity. And so this trade-off is visualized using these ROC plots. And so a good biomarker will look like this, with an area under the curve of 1. And so we have exactly that for this particular metabolite feature. It differentiates very nicely between infected and uninfected animals in male and female mice. And we have other candidates as well, like these ones here, that have still pretty good AUCs, 0.83, 0.9. And so we have now these urine metabolite features that can differentiate between infected and uninfected mice. But really the need is actually to predict disease progression rather than infection status. And I think this is strongly illustrated by the results of the benefit clinical trials. So what they did there is they started with patients with established heart disease, so late stage disease. And then they treated them with our standard antiparasitic benznidazole. And so what you see is that the benznidazole group in blue and the placebo group are very similar in terms of death or cardiac event rates. And so that means that if you wait until late stage, even killing off the parasites successfully might not improve patient outcomes. And so what we want really is biomarkers that can show disease progression rather than just infected versus uninfected. So we set up another mouse infection cohort. And so what we did is we chose the benznidazole dose there so that some mice would be completely cured, no more parasites left, and we call that treatment success. And other mice would still have parasites left over, and we call that treatment failure. And so this enabled us to validate our biomarkers in a third independent cohort because they show very nice differentiation between our uninfected mice and our treatment failure mice. But you'll notice that if you look at our treatment success mice, they basically look the same as the treatment failure mice. And so what we found is that those biomarkers did not renormalize even after killing off all the T. cruzi parasites in these mice. If we look at the overall metabolome, each of these spots is summarizing the metabolome of a specific mouse. And so what we find is that in gold, the treatment successes cluster with the pink treatment failures, and both of these cluster away from the uninfected control in blue. So even after you kill off all the T. cruzi, the urinary metabolome does not renormalize back to its uninfected status. Now, you can argue that this is in urine. Urine is not one of our Chagas disease symptom sites. And that's true, which is why we also looked in the heart. And so this is a collaboration with Dr. Jones at Baylor College of Medicine. And so they had 3 groups in this data here. So we have naive, uninfected mice, infected mice with lots of parasites. And then if we treat with benznidazole, we successfully clear the parasite numbers back to our baseline background numbers. Now, if we look at cardiac metabolism, what we find is that there is a significant change between the benznidazole treated mice and infected mice, only in the right ventricle. But there's still also a large difference to naive mice. And so if we cartoon this, looking specifically at the right ventricle bottom, you can think of infection as having a certain impact on metabolism. So benznidazole would be here, a small difference to infected, still large difference to naive. And so this indicates a lack of cardiac metabolic restoration after benznidazole treatment. And so this can help explain why patients do not improve if treatment is initiated late in disease. So what's going on? One aspect we noticed is that our benznidazole treatment didn't restore a lot of different immune parameters. And so our collaborators at Baylor had been developing this idea of vaccine-linked chemotherapy. So this idea that you first treat with benznidazole to kill the parasites, and then you add this therapeutic vaccine to help reset the immune response. And so we'll call this combo treatment here. And so looking at our combo treatment, it includes a slightly reduced dose, about a quarter reduced dose of benznidazole compared to the benznidazole alone therapeutic regimen. So we still have some parasites left compared to our benznidazole alone treatment group. But if we look at the effect on metabolism, you'll notice that with benznidazole, we only had a small change to infected. We have a much bigger change with our combination treatments. And then with benznidazole alone, we had a large difference between the benznidazole treated mice and the naive animals, whereas we have a smaller difference here. So if we go back to our cartoon where benznidazole is over here, our combination treated mice have better metabolic restoration. And so this indicates, firstly, that modulating the immune response is a good strategy to help address this limitation of benznidazole, but also that immunity itself is one of the major drivers of these metabolic changes that we see in tissue metabolism. We're also interested in directly targeting metabolism as a treatment for Chagas disease. And so since we had so many changes in acylcarnitines, we decided to investigate using carnitine itself as a treatment regimen. And so here we have 2 different infection conditions. This one here with 5,000 parasites leads to about 50% mortality by 3 weeks post-infection. And then this one here with 50,000 parasites leads to 100% mortality in our control group at 3 weeks post-infection. if we give the mice carnitine in the drinking water, we get no acute stage mortality, which is great, right? That's what you want from a drug development point of view. What's interesting is that this effect we see with carnitine is independent of changes in parasite burden. So in black is our vehicle control, blue is our carnitine group, and you can see that over time they have the exact same trajectories, even as we start losing our high dose control animals. And we can look at where the parasites are within the mice, and it's comparable as well between these groups. So what we've done here is induce disease tolerance, the ability to survive the negative consequences of infection without actually changing pathogen burden. So how did we do that? We looked first at immune responses. So each column is a mouse, each row is a particular cardiac cytokine or chemokine, and you can see that they look the same in the vehicle and the carnitine group. So carnitine is not acting by immunomodulation. Instead, what we found is that carnitine is helping restore cardiac metabolism. So here in this Picoy plot, these are cardiac samples. Each circle is one sample colored by experimental group. As expected, your vehicle group in green is significantly different in terms of cardiac metabolism than the uninfected group in gold. But then if you look at the carnitine group here in blue, they have as many parasites as our vehicle control, but they cluster with the uninfected samples. And so this means that our treatment is helping renormalize or restore cardiac metabolism in the carnitine treatment, even though there's still a lot of parasites there in the heart. And in association with that, what we find is that the carnitine-treated mice have about a third less of this BNP mRNA, which is an indicator of cardiac strain. So there's also better cardiac function in these carnitine-treated mice compared to vehicle control. And so we're actively continuing to develop carnitine as a treatment regimen for Chagas disease, primarily with a focus on combinations with benznidazole. Lastly, we're also interested in identifying backup treatments or backup strategies in addition to carnitine itself. And so one way we've been thinking about this is going beyond this idea of metabolic resilience in the different organs to ask whether specific metabolic pathways are themselves more or less resilient. And so we started with the impact of infection on these different lipid classes. So we find which metabolites are affected within this category. And then we look at how many of those are able to be restored by our existing treatments. And so we find that overall, we have pretty good restoration. Most of the infection-affected lipids go back to normal with treatments. On the other hand, when we look at nucleosides and related molecules, now you have the opposite pattern where most of them are not restored by treatment. And so this suggests that this pathway would be a valuable place to start developing new or combination therapeutic interventions. And so what I showed you today is firstly a metabolic explanation for Chagas disease symptom localization in both the heart and the gastrointestinal tract. And then a metabolic explanation for antiparasitic clinical treatment failure. And in turn, this gives us a non-invasive urine-based approach to monitor and assess new and better treatments. And then building on our metabolic data, we found a new candidate for Chagas disease treatment, carnitine, which in turn fed back into new mechanisms of disease tolerance in Chagas disease. And so we apply chemical cartography broadly to many different disease systems, helping us understand organ physiology, helping us understand why symptoms develop where they do in the body, and then a translational framework to find new pathways to treat disease, new ways to predict disease progression, and monitor treatment efficacy. And if I leave you with just one message today, it's the importance of thinking spatially when you're looking at metabolism and integrating spatial context into your understanding of disease. Now, this work involves very many people, including the wonderful members of my lab, my great collaborators, and the funding agencies supporting our work.